Welcome to the deep dive. Today we're venturing into a realm that's both incredibly fundamental to healthcare and, well, surprisingly intricate.
Yeah, we're talking disinfection and hand hygiene.
Exactly. And you might think, oh, washing hands, I know that, but digging into the science, the why behind it all.
Especially using the big guidelines, like from the CDC and WHO.
Right. It uncovers a fascinating and honestly vital area, whether you're, working in healthcare or just curious about staying healthy.
This should be really interesting.
We think so. We've got two powerhouses guiding us today.
Yep, the CDC's guideline for disinfection and sterilization in healthcare facilities. The 2008 one, but with a big update, just this June 2024.
Super current then.
And the WHO guidelines on hand hygiene in healthcare. These are basically the global standards.
Okay, so our mission today is to kind of distill the crucial bits from these huge guidelines.
Extract the really important knowledge, the insights.
Yeah, help everyone understand how healthcare settings work, like behind the scenes to cut down infection risks.
Through cleaning surfaces, equipment.
And that absolute cornerstone, hand hygiene.
Definitely.
We're hoping for some practical takeaways, maybe a few surprises too. Didn't know that moments.
Always good.
So let's just dive in. First things first. Disinfection versus sterilization. What's the actual difference? And what makes them work?
Okay, yeah, the core difference is really about thoroughness, I guess.
Thoroughness.
Well, disinfection aims to eliminate most of the harmful microorganisms. The pathogens on things like medical tools, countertops.
Usually with chemicals.
Usually liquid chemicals, yeah. But disinfection typically doesn't knock out the really tough survivors. Bacterial spores are super resilient.
Okay. So disinfection gets most, but not the spores. Then sterilization.
Sterilization is the heavy hitter. It's designed to wipe out everything, all microorganisms.
Including the spores.
Including the spores. It's like hitting the microbial reset button.
Okay, got it. Disinfection, strong clean, sterilization, total delete. But it can't be as simple as just like spraying something, right? What affects how well these things actually work?
Oh, you're spot on. It's way more than a quick wipe. Several things really impact how effective disinfection or sterilization is.
Like what?
Well, first, imagine cleaning a really muddy window. You'd get the big chunks off first, wouldn't you?
Yeah, obviously.
Same idea. If there's visible dirt, blood, organic stuff on equipment, the disinfectant has to work through that first. So prior cleaning is absolutely critical.
Makes sense. Get the grime off so the chemical can reach the bugs.
Exactly. And the amount of that organic and inorganic gunk, we call it the load, matters. It can actually soak up or neutralize the disinfectant.
Okay. What else?
The type and number of microbes themselves. Some are just naturally tougher than others.
Like those spores again.
Yep. Then there's the disinfectant itself, the concentration. Is it strong enough? And crucially, how long does it stay in contact with the object?
Contact time. You can't rush it.
Definitely not. Think of it like brewing tea need the right amount of leaves, enough steeping time, same principle.
Right.
And the object itself matters too. Is it smooth? Easy to clean? Or does it have tiny crevices, hinges, lumens, a little tube?
Places for microbes to hide.
Precisely. And biofilms, like, those slimy layers microbes form, they're notoriously hard to penetrate.
Ugh, biofilms. Okay.
Even things like the temperature and the pH, the acidity or alkalinity during the process can play a role.
Really?
Yeah, and for some methods like ethylene oxide gas sterilization, even the humidity in the room is important. It's a whole interplay of factors.
Wow, okay. It really is a science then, getting this right.
Yeah.
Now, the guidelines use some specific terms. Germicide, antiseptic, disinfectant, and those words ending in supricide. Can you break those down?
Sure. Think of germicide as the big umbrella term. It's basically anything that kills microorganisms, especially the harmful ones.
Okay, the general killer.
Right. Yeah, under that umbrella, you've got antiseptics and disinfectants. The key difference is where they're used. Antiseptics are specifically for use on living tissue, your skin, essentially.
Like hand sanitizer or iodine before a shot.
Perfect examples. Disinfectants, on the other hand, are only for inanimate objects, surfaces, instruments, floors.
Got it. So antiseptic for skin, disinfectant for stuff?
Exactly. And you absolutely do not want to mix them up. Using a strong surface disinfectant on skin, that could cause serious injury.
Right. Definitely don't want that. Okay, what about the anticide family? Viricide, fungicide.
Those just tell you what kind of microorganism is being targeted.
So viricide means kill.
Yeah. So viricide kills viruses, fungicide kills fungi, bactericide kills bacteria,
Simple enough. What about sporicide?
kills bacterial spores, those really tough ones we mentioned.
And tuberculouside?
That specifically kills the bacteria that cause tuberculosis, Mycobacterium tuberculosis. It's often used as a benchmark because TB bacteria are relatively resistant.
Okay, so it's important to know that, like, a bactericide won't necessarily kill spores.
Precisely. The spectrum of activity varies a lot between different agents. You need the right tool for the job.
That's a really helpful breakdown. Okay, let's get into some of the common disinfectants the CDC talks about. First up, alcohols. Ethanol, isopropyl alcohol. We use these constantly now. What are their main uses in healthcare settings?
Alcohols are definitely workhorses for certain jobs. The guidelines mention they're good for disinfecting things like thermometers.
The ones they put into your tongue?
Well, maybe oral or rectal thermometers, yeah. Also, pagers, scissors, stethoscopes.
Things healthcare workers carry around.
Right. And small surfaces, like the rubber stoppers on medicine vials or the outside of some equipment, they work by basically dissolving the outer membranes of microbes and messing up their proteins.
So quick surface disinfection.
Uh-huh. And interestingly, studies show 70% isopropyl alcohol can be pretty effective on ultrasound transducer heads, at least in controlled lab settings.
Cool, but I feel like there's a but coming. I remember the guidelines had warnings about alcohol.
That's a really critical point, yes. Alcohols are generally not recommended for sterilizing surgical or medical materials.
Why not? They seem strong?
Two main reasons. They don't reliably kill bacterial spores, and they don't penetrate protein-rich materials very well.
So if there's blood or tissue residue.
It can shield the microbes. Tragically, the guidelines mention fatal infections linked to mistakenly using alcohol to sterilize spore-contaminated surgical instruments.
Wow, that's serious.
Absolutely. And while they have been used for disinfecting things like flexible endoscopes.
Those camera tubes.
Yeah. That use has also been linked to infection outbreaks because it's not always reliable. And back to those ultrasound transducers effective in the lab, yes, but in busy ICUs, using alcohol wipes on them has actually been associated with bloodstream infection outbreaks.
So the real world is messier than the lab.
Always. It really highlights how crucial proper selection and use are. Good for some things, definitely not a universal sterilizer.
Okay, noted. Useful, but with big limitations. Next, hypochlorites. That's basically bleach, right?
Yep. Sodium hypochlorite solutions. Bleach. Very common in healthcare for certain tasks.
What?
The CDC mentions disinfecting tonometer heads, those things that touch your eye to check the pressure.
Oh, right. Definitely want those clean.
For sure. And just general spot disinfection of surfaces like countertops, floors. And they're the go-to at specific dilutions for cleaning up blood spills.
Okay, seems like the heavy lifter for spills and surfaces. Any downsides or things to know?
Big one. Bleach, like many disinfectants, gets significantly inactivated, weakened by blood and other organic stuff.
Ah, so back to that cleaning point again.
Always. Clean the surface first, then apply the bleach solution for it to work properly.
Clean first, then bleach.
Got it.
Got it. Moving on, formaldehyde. That sounds pretty intense. How's that used?
Formaldehyde is intense. It's a very powerful disinfectant and can even be used as a sterilant, often as a liquid solution called formalin.
And it works against?
Pretty much everything. It's a broad-spectrum biocide, kills bacteria, including TB, fungi, viruses, and even spores.
Wow. Okay, but intense usually comes with safety warnings.
Definitely. Formaldehyde is a potential carcinogen, according to OSHA, the Occupational Safety and Health Administration.
Oh.
Yeah. They have very strict limits on workplace exposure. Swallowing it can be fatal, and long-term exposure to even low levels in the air or on skin can cause asthma-like respiratory problems and skin irritation.
So healthcare workers need to be really careful.
Absolutely. Direct contact needs to be minimized. It requires careful handling, good ventilation, protective gear.
Sounds like something for a very controlled situation.
Yeah.
Okay, what about glutaraldehyde? That's another name you hear a lot with medical equipment.
Right. Glutaraldehyde is also a high-level disinfectant, and it can be used as a chemical sterilant if you soak items for long enough.
High-level disinfectant. What does that mean exactly?
It means it kills all vegetative microorganisms, mycobacteria, viruses, fungi, and some, but not necessarily all, bacterial spores. Sterilization kills everything, including all spores.
Gotcha. So glutaraldehyde is strong, but maybe not quite sterilant level unless used for a long time?
Exactly. And its effectiveness can vary. It can be slow against certain mycobacteria, for example. And interestingly, its activity is quite dependent on temperature.
Oh,
Yeah, if the solution is too cold, it might not achieve high-level disinfection, even against TB within the typical time frame, say 10 minutes. Some newer formulations actually use higher temperatures to speed things up.
huh. Quirky. Safety concerns here, too.
Yes, definitely. Glutaraldehyde vapor is hazardous. It can irritate the eyes, nose, throat. It's also linked to occupational asthma and skin problems like dermatitis in healthcare workers.
So similar precautions needed as with formaldehyde.
Pretty much. Good ventilation is key exhaust hoods, lots of air exchange, personal protective equipment like right kind of gloves, nitrile or butyl rubber, eye protection, and monitoring the air levels is recommended.
ECGIH. I saw that mentioned.
Yeah, the American Conference of Governmental Industrial Hygienists. They set exposure limits. If levels are too high, you have to take action. And for disposal, if you can't pour it down the drain, you can neutralize it with sodium bisulfate.
It really sounds like a constant balancing act, killing the microbes versus protecting the people using the chemicals.
It absolutely is. Safety protocols are paramount.
Okay, let's shift to iodine and iodophores, like povidone iodine, the brown stuff. We see that used on skin a lot. Does it work on objects too?
Iodophores do have broad antimicrobial activity, yes. They can kill bacteria, mycobacteria, viruses.
So pretty good.
Generally, yes. But the CDC guidelines note they might need longer contact times to be effective against certain fungi and bacterial spores. Their strength depends on the amount of free iodine available in the solution.
Free iodine?
Yeah, the active part. Interestingly, sometimes diluting povidone iodine actually makes it kill certain bacteria faster than the concentrated stuff.
Weird. Okay. Any limitations?
Well, there's some debate about how well they work against certain non-enveloped viruses, especially if there's organic matter present. And manufacturers usually don't claim they kill spores, though they are generally effective against TB, fungi, and other bacteria and viruses at recommended dilutions.
So broad spectrum, but maybe not a total knockout punch, and organic stuff can still interfere.
Got it. What about peracetic acid?
Peracetic acid is interesting. It's an oxidizing agent, works differently than some others by damaging essential parts of the microbial cells.
And its effectiveness.
The guidelines highlight it's effective against a really wide range of microbes, bacteria, fungi, yeasts, viruses, mycobacteria, and spores.
Spores, too. That's significant.
Yeah. And often it works very quickly, sometimes under 5 minutes, even at low concentrations. Another big plus.
Yeah.
It tends to stay effective even when organic matter is present.
Oh, that is a big advantage in real-world cleaning.
Definitely. Though the exact concentration needed can still vary depending on the specific bug you're targeting.
Okay, peracetic acid sounds like a powerful option. Last one in this group, quaternary ammonium compounds. Quats. We see those in household cleaners. What about healthcare?
Quats are pretty common. They're generally good at killing fungi, regular bacteria, and enveloped viruses. Those are viruses with a fatty outer layer.
Like flu viruses. Yeah, flu, HIV, hepatitis B and C are examples, but they're generally not effective against bacterial spores.
Yeah.
And they aren't reliably tuberculocidal, nor are they great against non-enveloped viruses, the ones without that fatty coat, like norovirus.
So more limited spectrum.
Right. They work by messing with the microbe's cell membranes and energy production. Interestingly, studies showed quats and also alcohol wipes can be good for cleaning things like computer keyboards in hospitals, removing resistant bacteria without damaging the keys.
That's practical. Any downsides?
There have been some reports linking certain quats to occupational asthma, so still need careful use.
Okay, so quats are useful for certain routine cleaning, especially for those enveloped viruses, but not the go-to for everything. This gives us a much better feel for the different tools in the disinfection toolkit.
Yeah, each has its place, its strengths, and its weaknesses.
Now, what about sterilizing things that can't handle heat? Delicate medical devices. What low-temperature sterilization methods do the guidelines mention?
Right. For heat and moisture-sensitive items, the big one historically has been ethylene oxide, or ETO. It's been used since the 1950s.
Still common?
Yeah, it was the most common low-temp method in the U.S. for these devices, according to the 2008 guideline. There are basically two main types of ETO sterilizers.
Okay, ETO sounds essential then, but I seem to recall hearing about drawbacks. Toxicity, maybe.
Yes, absolutely. ETO has significant safety considerations. First, it gets absorbed by many materials.
So it stays in the device.
It can, yeah. So after sterilization, items need aeration, basically airing out to remove residual ETO. There are strict limits on how much can remain.
Because it's harmful.
Yes, it's toxic. Animal studies show that, and in humans, exposure can cause eye irritation, breathing problems, dizziness, nausea.
Just immediate effects.
No, also more serious long-term issues. It's been linked to cancer, genetic damage, nerve damage, even cognitive problems, and occupational exposure.
For healthcare workers using it.
Right. It's been associated with increased risk of miscarriages and certain cancers. OSHA has set a permissible exposure limit, a PL, for ETO in workplace air to protect workers.
Wow. That's a heavy list. So using ETO requires incredibly strict safety protocols and monitoring.
Without a doubt. Ventilation, containment, monitoring, aeration, all crucial.
Are there alternatives? Other low-temp methods?
The guidelines briefly mention others, like hydrogen peroxide gas plasma and liquid parasitic acid systems, which we already discussed as a disinfectant, but it can also be used in automated systems for sterilization of immersible items like endoscopes.
Okay.
They also touch on gaseous chlorine dioxide. It was known back then as a fast-acting sterilant, effective against spores. But at the time of the 2008 guideline, it hadn't yet received FDA clearance for use in healthcare.
Gotcha. And regardless of the method.
Cleaning first. Research shows that even with these advanced low-temp methods, thorough cleaning to remove salts, organic stuff, it's absolutely essential for them to work effectively.
Cleaning is king. Always comes back to that. Now, let's focus on one specific type of device you mentioned, endoscopes. The guidelines have a whole section on them. Why are they such a big focus?
Endoscopes, those flexible tubes with cameras, are amazing tools. But they're heat sensitive, so you can't just autoclave them like metal instruments.
Right. Low-temp sterilization or high-level disinfection.
Exactly. And how they are cleaned and disinfected after every single use is incredibly important. Because, unfortunately, contaminated endoscopes have been linked to more healthcare-associated infection outbreaks than any other medical device.
Really? More than any other.
That's what the data indicated. Even though the overall risk per procedure might be low, the sheer number of procedures and the complexity of cleaning these devices means the potential for transmission is significant if protocols aren't followed perfectly.
So what's the minimum standard for reprocessing them?
Meticulous cleaning, followed by at least high-level disinfection after every procedure. That's the baseline.
High-level disinfection. Does that kill everything, including spores?
It's expected to kill all microorganisms, but the CDC guideline acknowledges that if there is an unusually high load of bacterial spores, a very small number might survive HLD. Sterilization is the only process that guarantees spore kill, but HLD is considered sufficient for semi-critical devices like endoscopes that contact mucous membranes.
Okay, so the key is following the rules precisely.
Absolutely. Facilities must strictly follow published, validated guidelines. But audits have shown, well, inconsistent adherence among staff. It's complex.
So training is key.
Huge. The guidelines stress initial and annual competency testing for everyone involved in reprocessing endoscopes. You have to prove you know how to do it right, consistently.
No room for error with endoscopes.
Yeah.
Okay, let's switch settings now to our own homes. The CDC guidelines touch on home disinfection. What's the advice there? Is it different from hospitals?
It is different, yeah. The guidelines acknowledge public concern about overusing antimicrobials at home and the potential link to antibiotic resistance.
The idea that we might be creating superbugs in our kitchens.
Kind of, yeah. The CDC basically says it's an unresolved issue, needs more research. The public health benefit of routine, widespread home disinfection isn't fully established.
So we don't need to bleach everything constantly?
Probably not. But some things are clear. Kitchens and bathrooms can harbor microbes. Using hypochlorite bleach is effective at reducing bacteria levels there.
Right.
And the guidelines really reinforce that basic good hygiene, proper food handling, thorough hand washing is crucial at home for preventing infections.
So focus on the basics.
And maybe targeted hygiene. That's a concept the guidelines mention.
Targeted hygiene.
Yeah, focus disinfection efforts on specific times and places where there's a higher risk of spreading germs, like surfaces used for raw meat prep or after someone's been sick, or bathroom surfaces, not necessarily trying to sterilize the whole house all the time.
That sounds much more practical. Focus where it counts.
Yeah.
Okay, let's talk about the methods of cleaning, which we keep saying is so important. Manual versus mechanical.
Right. Manual is just scrubbing with detergent and water. Mechanical uses machines.
Like what kind of machines?
Common ones are ultrasonic cleaners. They use sound waves, cavitation to loosen debris. Think jewelry cleaners, but bigger.
Okay.
Then there are washer decontaminators or washer disinfectors, kind of like industrial dishwashers. Some might have a heat cycle for disinfection. And washer sterilizers, which are like modified steam sterilizers that also wash first.
Does cleaning itself kill microbes or just remove them?
Mostly removes them, but that makes a huge difference. Studies on endoscopes showed cleaning alone can give like a 4-log reduction in microbes.
4-log? That sounds like a lot.
It is. It means reducing the number by 99.99% just by physically removing the soil and contaminants.
Wow. So cleaning is incredibly effective on its own. Any downsides to the machines?
Well, the cleaning solutions themselves, especially in ultrasonic cleaners, can become contaminated with bacteria if they don't have an antimicrobial agent in them.
So the cleaning water could get germy?
Potentially, yeah. There's also a theoretical concern about endotoxins, parts of dead bacteria, getting onto instruments from the fluid, which could cause reactions in patients.
But are the machines generally better than scrubbing by hand?
Studies suggest they can be more consistent and efficient, especially for complex instruments. Automated methods often remove different types of soil, like protein and hemoglobin, more effectively than manual cleaning in some comparisons.
So pros and cons, but automation can help with consistency. Now, how do hospitals know if sterilization or high-level disinfection actually worked? How do they monitor it?
Monitoring is absolutely vital. Quality control. They use chemical and biological indicators.
Okay, what's the difference?
Chemical indicators are usually strips or tapes that change color when exposed to certain parameters of the process, like heat, steam, or a specific chemical for a certain time.
So they show it went through the cycle.
Exactly. They're
Right.
relatively cheap, easy to read, show it's been processed. But, and this is key, they don't prove that microbes were actually killed.
So how do you prove that?
That's where biological indicators, or BIs, come in. These contain live, highly resistant bacterial spores.
The toughest bugs.
Right. After the sterilization cycle, the BI is incubated. If the spores grow, the cycle failed. If they don't grow, it worked.
So the BI is the real proof of kill.
Yes. The CDC stresses that chemical indicators should be used with BIs but never replace them. Only the BI directly measures the killing power.
Okay, so you might see both on a sterilized pack.
Often, yeah. An external chemical indicator on the outside to show it's been processed, and ideally an internal one inside the pack to check the sterilant penetrated. Plus, for certain steam sterilizers, there's a daily test called the Bowie-Dick test.
Bowie-Dick.
Yeah, it checks if the sterilizer is removing air properly from the chamber, which is essential for steam to work effectively.
So multiple checks and balances. Makes sense for something so critical. Now, what about flash sterilization? That sounds fast.
It is fast. It's defined as sterilization of an item for immediate use.
Like in an emergency.
Exactly. The classic example is if a crucial surgical instrument gets dropped mid-procedure and needs to be re-sterilized right now.
Okay. So it's not for routine stuff.
Definitely not.
Yeah.
The guidelines have several big caveats. It should only be used for immediate needs, not for convenience. Only for instruments that can be fully immersed.
What about monitoring? BIs take time to incubate.
Right. Routine BI monitoring might not be feasible for every flash cycle because of the speed needed, though BI should still be used periodically to verify effectiveness, often daily or weekly depending on the sterilizer type and standards. And usually you can only process one instrument or a very small load at a time.
Other downsides.
It can be more expensive. If using liquid chemical sterilants for flashing, there's a risk of serious eye skin damage from concentrated solutions. And critically, items flash sterilized cannot be stored. They must be used immediately.
No putting it on the shelf for later.
Nope. You need sterilizers and packaging specifically designed and validated for flash cycles. It's a specialized process for agent situations.
Okay, very clear. Emergency-only strict rules. Now, we've covered objects and surfaces thoroughly. Let's pivot to the other massive piece, hand hygiene. The WHO guidelines are a key resource here. How do they frame the importance of clean hands?
The WHO guidelines are really the global standard, building on earlier work like the CDC's 2002 guidelines. Their goal is optimal hand hygiene everywhere, regardless of resources.
Universal best practice.
Right. They start by defining terms clearly, like plain soap, just regular soap, no extra antimicrobials, waterless antiseptic agent, that's your hand rub or sanitizer.
Okay.
Then antiseptic hand washing, washing with soap that has an antiseptic, and antiseptic hand rubbing, using that waterless agent the hand rub.
Got the terminology. Now, why is hand hygiene so central? They talk about HAIs, right?
Yeah.
Healthcare-associated infections.
Yes, HAIs are a huge global problem. The WHO highlights that developing countries often face much higher rates than developed ones.
Significantly higher.
Yeah, studies in ICUs, neonatal units, show rates several times higher sometimes. Common risk factors are things like long hospital stays, surgery, catheters, being sedated.
And hands play a big role in spreading these.
A primary role. Healthcare workers' hands touch patients, touch the environment, equipment. They can easily become contaminated with pathogens.
And then move them to the next patient or surface.
Exactly. They become vectors for transmission.
Does the WHO provide evidence for this hand contamination?
Oh, tons. They cite numerous studies, even going back before gloves were common, showing healthcare workers' hands contaminated with things like Staphylococcus aureus, gram-negative bacteria, sometimes in really high numbers.
So the bugs are definitely there on hands.
Yes. And modeling studies predict that even small improvements in hand hygiene compliance, how often people actually clean their hands when they should, can have a big impact on reducing transmission, especially if compliance is low to begin with.
Small changes, big results potentially. And is there direct evidence linking better hand hygiene to fewer infections?
Absolutely. While big randomized trials are tough to do, there's a large body of evidence showing that improving hand antisepsis reduces pathogen transmission and lowers HAI rates.
Like the famous Semmelweis story.
Exactly. Ignaz Semmelweis in the 19th century dramatically cutting maternal deaths just by having doctors wash hands with an antiseptic between patients. It's a historical proof of concept.
And more recent studies.
Yep, studies showing changing antiseptic soaps reduced MRSA spread or increased hand washing cut Klebsiella transmission. But the WHO is clear. Success usually comes from multimodal strategies.
Multimodal. Meaning?
Not just one thing, a combination education, making hand rub available, reminders, feedback, institutional support, a whole package deal.
Okay, systems approach. Now, how do they actually test if a hand rub or soap works well? You mentioned in vivo methods.
Right, in vivo means in the living, so they test on volunteers' hands. They deliberately contaminate the volunteers' hands with a standard type and amount of bacteria, like E. coli. Then the volunteer uses either the test product or a reference solution, and researchers measure how much the bacteria count is reduced.
So controlled hand dirtying.
Pretty much. They mention European standards like EN 1499 for hygienic hand wash and EM 1500 for hygienic hand rub, which use this kind of method with a crossover design.
Okay, that gives objective data on how well products kill germs on actual skin. Now, what about the water used for hand washing? Can that be an issue?
It can be. Tap water isn't sterile. It can contain microbes, and sometimes minerals or chemicals in the water can even interfere with antiseptics.
So hospitals need good water quality.
Yes, water for hand washing in healthcare needs to meet local regulations. Facilities need to maintain their water systems. If contamination is a concern, they might filter or disinfect the water.
How do they disinfect water?
Common methods are adding chlorine, monochloramine, chlorine dioxide, ozone, or using UV light. Each has pros and cons, like chlorine can create disinfection byproducts.
So even the water needs careful management. Okay, let's focus on alcohol-based hand rubs. They're everywhere now. What makes them so highly recommended by WHO and others?
Well, tons of studies show they're very effective at killing microbes on hands, and quickly. Often significant log reductions in bacteria in just 15-30 seconds.
Log reductions again. Big drops in numbers.
Right. And regulatory bodies like the US FDA recognize ethanol and isopropanol as safe and effective active ingredients. They also work against many non-enveloped viruses.
The tougher ones without the fatty coat.
Yeah, like rotavirus, adenovirus, rhinovirus. Though effectiveness against others like hepatitis A or enteroviruses can vary based on the alcohol concentration, time, and specific virus. Some studies even show alcohol rubs beat medicated soaps against certain viruses.
Fast and broad spectrum. Big pluses. But what about the drying effect? People complain about that.
That's a real concern with frequent use. Alcohol itself can be drying, but most healthcare hand rubs contain humectants moisturizers like glycerol.
And that helps.
Significantly. Clinical trials show alcohol rubs with humectants often cause less skin irritation and dryness than washing repeatedly with soap and water, even antiseptic soaps.
Really? Less irritating than soap.
Often, yes. While some people might get stinging on broken skin or rare allergies to additives, overall, systematic reviews conclude alcohol rubs are more effective, faster, and better tolerated by skin than soap and water.
And better tolerance probably means people use them more often.
Exactly, better compliance. They're also highly effective for surgical hand preparation.
Okay, so the benefits generally outweigh the downsides,
Mm-hmm.
especially with moisturizers added. What about other hand hygiene agents? Iodine, chlorhexidine, triclosan.
Right, the WHO touches on those too. Iodine iodophores, as skin antiseptics, have broad activity by disrupting proteins. Chlorhexidine also has broad activity and good persistence. It keeps working for a while after application.
Persistence is good. Downsides.
Chlorhexidine is better against gram-positive than gram-negative bacteria, can cause skin irritation, and very rarely serious allergic reactions, anaphylaxis.
Okay. And triclosan. It used to be in lots of consumer soaps.
Yeah, it works by messing with bacterial membranes and synthesis. It's broad, but often bacteriostatic inhibits growth rather than killing outright. Better against gram-positives like MRSA than gram-negatives.
Any issues?
It has some persistence. Some studies linked it to reduced MRSA, but there were also reports of products getting contaminated. It's not reliably sporicidal, and the FDA has significantly restricted its use in consumer antiseptic washes due to lack of data on long-term safety and effectiveness.
So different agents, different profiles. Now, a really specific important pathogen, Clostridium difficile or C. diff. Big problem in hospitals. What's the hand hygiene rule for C. diff?
This is super important. The WHO guidelines state clearly, no common antiseptic hand wash or hand rub agents are reliably sporicidal against C. diff spores.
Not even alcohol rubs.
No, alcohol kills the vegetative C. diff bacteria, but not the spores. And stores are how it spreads and survives.
So what do you do for C. diff?
Mechanical friction with plain soap and water. You need to physically wash the spores off your hands. Antiseptics in the soap don't really help remove spores better than plain soap.
Just washing them down the drain?
Essentially, yes. Plus, contact precautions, gloves, and gowns are crucial when caring for C. diff patients.
Do you use alcohol rub at all with C. diff?
You can use it after washing thoroughly with soap and water for extra protection against other things, but soap and water must come first for spore removal. For all other routine situations, alcohol rub remains the preferred gold standard.
Key distinction. Soap and water for C. diff spores. Alcohol rub for most everything else.
Got it.
Got it. Now, WHO actually provides formulations for alcohol rubs and talks about local production.
Yeah, this is really cool. They developed specific formulations balancing efficacy, local production feasibility, and cost, trying to make effective rubs accessible everywhere.
So hospitals, pharmacies could make their own.
Potentially, yes, especially in resource-limited settings. WHO encourages governments and facilities to support local production, ensure quality control, and keep costs down.
Any safety issues with making it locally? Alcohol is flammable.
Huge consideration. Undiluted ethanol is very flammable. The WHO formulations are diluted, which reduces risk, but they still have flashpoints making them flammable. Safe storage is essential, cool, ventilated areas, away from flames or sparks. They advise against large-scale production in non-specialized pharmacies and stress following all safety regulations.
Okay, so empowering local production, but with strict safety rules. What about practical day-to-day stuff? Gloves, jewelry, fingernails, how do they fit into hand hygiene?
These details matter. Gloves are part of standard precautions, protect the patient, protect the worker. But crucially, you need hand hygiene before putting gloves on and immediately after taking them off.
Why after? Aren't your hands clean under the gloves?
Not necessarily. Gloves can have tiny holes you can't see or hands get contaminated while removing them. Gloves are not a substitute for hand hygiene.
Good point. Jewelry. Rings.
Studies show skin under rings harbors more bacteria. So the recommendation is minimize or avoid jewelry, especially rings, during direct patient care.
Fingernails. Artificial nails.
The space under nails can harbor lots of microbes. Longer nails, artificial nails associated with higher bacterial counts and even infection outbreaks. So short, natural nails are recommended. Discourage artificial nails for direct care providers.
That makes sense. And having sinks and dispensers available.
Absolutely. Critical infrastructure, accessible sinks, ideally with drinkable water, maybe non-touch faucets, and strategically placed alcohol rub dispensers right at the point of care where care is delivered.
Easy to reach when you need it.
Exactly. They discuss dispenser types too. Reliability, ease of use, preventing contamination. Things like disposable cartridges, visible fill levels are good features.
So the whole environment needs to support good practice. Now, interestingly, WHO even considers cultural and religious aspects. Why is that important for hand hygiene?
Because hygiene behaviors are often deeply rooted in culture and religion. Some faiths have specific ritual washing practices. Others might have restrictions on alcohol use.
Which could affect using alcohol-based rubs.
Potentially, yeah. If a healthcare worker's faith prohibits alcohol, they might be reluctant. The guidelines suggest culturally sensitive education and promotion are needed. Acknowledge beliefs, provide alternatives where appropriate, like ensuring good access to soap and water, and explain the rationale clearly and respectfully.
That's a really thoughtful inclusion. Okay, finally, let's talk about improving compliance. How do you actually get healthcare workers to clean their hands more often? What strategies work?
This is the million-dollar question. The WHO stresses a multifaceted approach is needed. Just educating people isn't enough.
So what are the facets?
They outline the WHO multimodal hand hygiene improvement strategy. It has 5 core components.
5.
Okay. 1, system change, make it easy. Accessible hand rubs, functioning sinks. 2, training and education, the why and how. 3, monitoring and feedback, observing practice, telling people how they're doing. 4, reminders in the workplace, posters, prompts. 5, promoting an institutional safety climate, making hand hygiene a clear priority, leadership support, everyone feeling responsible.
Sounds comprehensive. System, education, monitoring, reminders, culture.
Exactly. And strong leadership support is vital. Plus, they have the 5 moments for hand hygiene.
The 5 moments?
Yeah, a framework defining when hand hygiene is critical. 1, before touching a patient. 2, before clean or the aseptic procedure. 3, after body fluid exposure risk. 4, after touching a patient. 5, after touching patient surroundings.
Super clear guidance on the when.
It makes it very practical for staff.
You mentioned education isn't enough on its own, but it's still part of the strategy. What makes educational programs effective?
Successful ones are usually multidisciplinary, ongoing, not just a one-off lecture. They tailor guidelines to the local context, maybe focus on a few key recommendations, consider cultural norms.
And WHO even suggests using marketing principles, the 5 Ps.
Yeah, it's an interesting angle. Product, the hand rub soap, the practice itself. Price cost, time, skin irritation, actual cost. Place, accessibility, promotion, reminders, campaigns. And people partners, engaging everyone, thinking about how to sell hand hygiene.
Applying business strategy to public health. Clever. And measuring compliance, you mentioned observation.
Direct observation is common, yeah. Trained observers watch care and record hand hygiene actions at the 5 moments. It gives direct data.
But people might act differently if they know they're being watched.
That's the Hawthorne effect, or observer effect. It's a known bias. Strategies exist to minimize it, like observing discreetly or for longer periods, but it's important to acknowledge accurate measurement requires clear definitions of opportunities versus actual actions.
And is improving hand hygiene cost-effective?
Overwhelmingly, yes. Studies consistently show that investing in hand hygiene programs saves money in the long run by preventing costly HAIs.
Makes sense. What about bigger picture stuff? National campaigns, patient involvement.
WHO notes national campaigns can work, citing examples like the Clean Your Hands campaign in England and Wales. Central coordination, funding, consistent messaging helps.
And empowering patients.
Yeah, involving patients, educating them, encouraging them to ask providers, did you clean your hands? It adds another layer of accountability and reinforces the importance for everyone.
Patients as partners in safety. I like that. So across all these guidelines, CDC, WHO, are the messages pretty consistent?
The core principles, absolutely. Clean hands save lives. Use alcohol rub generally, soap and water for visible soil, or C, diff. Disinfect surfaces appropriately. The exact terminology might differ slightly between documents sometimes, which can make direct comparisons tricky, but the fundamental goals and evidence-based practices are very much aligned.
Okay. Well, this has been incredibly thorough, a real deep dive into the science and practice here. To try and sum up.
It's complex. Yeah. Disinfection and hand hygiene are multifaceted, absolutely critical for preventing HAIs.
Right. And understanding the specifics, which disinfected for what, why contact time matters, the evidence behind hand hygiene methods. It's crucial for healthcare workers, obviously, but also helpful for all of us to understand.
Definitely. And hopefully, by exploring these guidelines, our listeners have a deeper appreciation for all the measures taken, often unseen, to keep healthcare environments safe.
And maybe feel better equipped to understand public health advice in general.
Yeah, the principles apply broadly.
So a final thought for everyone listening. Think about that invisible world of microbes, the constant battle against infection in hospitals and clinics. What responsibility do we all share, individuals, society, in supporting these fundamental practices?
And what questions do you have now? What's next in research? It's an ongoing field.
Absolutely. Thanks for joining us for this deep dive.